Dear students, I am Dr. Malcolm, your faculty of dermatology at Marrow. Today's session will be talking about the NEET-PG 2023 exam dermatology questions. So these were the important topics which were asked in the NEET-PG 2023 exam. Number 1, appendages and disorders. Number 2, eczema and dermatitis. Number 3, pigmentary diseases. Number 4, sexually transmitted diseases. Number 5, infections, especially with HIV. Lot of overlap topics with nutritional dermatosis. Now, what we can see is remarkably the absence of papillosquamous disorders, which was not asked. Then we didn't have any questions from Hansen's disease as well, because a majority of questions came from sexually transmitted diseases. Just want to highlight this fact once again that STDs are very, very important from the point of view of microbiology, dermatology, gynecology, as well as from community medicine. Let's begin with a discussion of question number 1. 35-year-old obese female with acne who is not improving in spite of being on multiple cycles of antibiotics and isotretinoin. What is the next best step? Option number A, investigate for drug history causing acne. Option number B, investigate for food habits. Option number C, investigate for antibiotic resistance. Option number D, investigate for hyperandrogenism. So when we look at this question, the key words are a 35-year-old obese female. So the examiner is trying to draw our attention to the fact that she probably has polycystic ovarian syndrome because she is not improving in spite of being on antibiotics and isotretinoin. So we cannot take option number C, antibiotic resistance, because generally in antibiotic resistance, isotretinoin works. And if antibiotics as well as isotretinoin, one of the best drug in acne, is not working, we have to think about hormonal causes. And many students told us that in the exam, the picture which was shown of the patient also had the presence of hair, which is adding to the fact that she probably had hirsutism. So in the presence of hirsutism and acne, a patient who is not responding to conventional therapies like antibiotics and isotretinoin, the correct answer would be to look for hyperandrogenism. Now, in relation to acne, we have to remember that there are two important syndromes. Number 1, Saha syndrome, which stands for seborrhea, acne, hirsutism, early onset androgenetic alopecia. So very important, Saha syndrome, which stands for seborrhea, acne, hirsutism, androgenetic alopecia, early onset. And there's one more syndrome called as Hair-Ann syndrome, which is going to be standing for hyperandrogenism, insulin resistance, acanthosis nigricans. Very important is one of the feature to remember about hormonal acne is this usually involves the mandibular area. It generally involves the mandibular area, to be precise, the lower face acne. So lower face acne in an adult, always think about hormonal acne. Now, regarding the diet which can trigger acne, 2 points to remember. Number 1, dairy products. Number 2, foods with high glycemic index. Both of them can cause the release of insulin like growth factor 1, which can in turn block the sebaceous duct. In that list of drugs which trigger acne, number 1, systemic steroids. Number 2, lithium. Number 3, isoniazid. Number 4, progestin contraceptives. And number 5, epidermal growth factor receptor inhibitor. So these are the important drugs that we need to keep in mind. Second question, lady with periorbital and facial edema. History of hair dye usage. The chemical present in hair dye causing it is option A, pollen. Option B, balsam of Peru. Option C, PPD. Option D is chromate. Now, the question says hair dye. And when we look at the facial edema, periorbital edema, what is the diagnosis here? The diagnosis is going to be allergic contact dermatitis to hair dye. So in a patient who has allergic contact dermatitis to hair dye, what is the allergen? Straightforward question in the exam, paraphenylenediamine, option number C. Now students, what is allergic contact dermatitis? So it is a type of contact dermatitis which is immunologically mediated. Type 4 hypersensitivity reaction. And please remember, the investigation of choice in this allergic contact dermatitis is going to be patch test. Which again is an example for type 4 hypersensitivity reaction. So we just learned that there are two important examples for type 4 here. Number 1, allergic contact dermatitis, and number 2 is patch test. Now let us look at the common allergens which can trigger ACD. So number one, in cement, it is going to be potassium dichromate. So the allergen in cement is potassium dichromate. In metal, in artificial jewelry, we're thinking about nickel as a common cause of ACD. In plants, the most common plant in India which can trigger this kind of contact dermatitis is Parthenium hysterophorus. Parthenium hysterophorus. Please remember, students, that Parthenium hysterophorus is the plant. The name of the allergen here is SQL, which is going to be standing for sesquiterpene lactone. Then moving on to topical antibiotic, which generally we don't give in dermatology because we are always scared that it can produce allergic contact dermatitis, is going to be neomycin. This is going to be neomycin. And next, in bindi dermatitis, the allergen which is implicated is PTBP, which is going to be standing for tertiary butyl phenol. Para tertiary butyl phenol, which can also produce chemical leukoderma, loss of melanocytes due to the destructive action of the PTBP. Next question. What is the long-term complication of this condition? Option A, cataract. Option B, glaucoma. Option C, malignant melanoma. Option D, progressive loss of vision. Now, if we look into this image, what do we see here? We see that there is an image here showing a unilateral lesion. So we can see this is on one side of the face. Number two, if we were to look at the color is hyperpigmented. Number three, very conspicuously, you can see the irregular surface and the presence of hair. So once there is hair on the lesion, we are going to be calling it as a hypertrichotic lesion. So in this background, where a patient has a unilateral lesion, hyperpigmented lesion, hypertrichotic lesions, we have two important differential diagnoses. If the lesion is at birth, we call it as congenital melanocytic nevus. If this is at birth, and if the lesion is acquired during puberty, we call it as Becker's. But please remember, what is against Becker's here is probably it was acquired. And number two, Becker is usually common on the chest and the upper shoulder. Congenital melanocytic nevus, you can get it anywhere, but Becker, generally in the exam, they're going to be showing you a chest or upper shoulder kind of an image. So with this picture, the best diagnosis here would be congenital melanocytic nevus. And now further, when we look at the options, what do we realize? We realize that when we're talking about congenital melanocytic nevus, if the size is more than 20 centimeters, we call it as a giant congenital melanocytic nevus. And if there's a patient with a giant congenital melanocytic nevus, there is a 2 to 5% chance of developing malignant melanoma. That's why the correct answer for this question is malignant melanoma. Next question. A young woman comes with complaints of a painless ulcer in the genital area. She also has non-tender inguinal lymphadenopathy. What is the likely diagnosis? Option A, syphilis. Option B, granuloma inguinale. Option C, chancroid. Option D, genital herpes or herpes simplex. Now, whenever there's a genital ulcer disease question coming in the exam, we have to look at two aspects. Number one, we look at the genital ulcer. Number two, we look at the inguinal lymph nodes. So these are the 2 points that we are going to consider here. When we look at the genital ulcer, let us try to classify them. So there are 5 ulcerative STDs which have genital ulcers. So we can broadly classify them into single and non-tender, multiple and tender. In the first category, there are 3. Second category, there are 2. In single and non-tender, we have to remember number 1, primary syphilis. Number 2, donovanosis. Number 3, lymphogranuloma venereum. Very, very important. And in multiple tender genital ulcer, just 2 causes to remember. Number 1, chancroid. Number 2, genital herpes. Genital herpes. Now, when we are looking at bilateral tender inguinal lymphadenopathy, first we look at no bubo formation or bubo formation. In no bubo formation, we are going to be talking about genital herpes. And 2 genital ulcer diseases which can produce bubo. Number 1, chancroid. Number 2, LGB. And usually the bubo in chancroid is unilateral. And here it is unilateral in 2/3, bilateral in 1/3. So this is one thing you need to remember. And now what you see in the question, you're going to see that the patient is going to present with a painless ulcer. So when you're talking about a painless ulcer, what you have to remember here is two options cannot be the answer. Chancroid and herpes are out because both of them produce the presence of multiple tender ulcers. So these cannot be the answer. Granuloma inguinal cannot be the answer because the question says non-tender inguinal lymphadenopathy. Here, the inguinal lymph nodes are normal. So this cannot be the answer. The correct answer is primary syphilis, option number A. Next question. Wife of a truck driver with multiple sexual partners presents with dysuria and vaginal discharge. On examination, cervical erosion is present. Which color STD kit should be given to this patient? Option number A, gray. Option number B, green. Option number C, red. Option number D, blue. So when we're talking about these color-coded kits, these are provided by the National AIDS Control Organization. And we are talking about the whole management here from community medicine point of view, which is going to be given the name of syndromic management. In syndromic management, what do? We use clinical algorithms, especially in those places where lab facilities are not there or proper facilities for a consultant is not there. So there are no adequate lab facilities and no medical facilities as well. Wherein here we are going to be diagnosing based on symptoms and signs. So please remember that both symptoms as well as signs are required for the treatment of these patients. So the symptom which is given here is a vaginal discharge. Now what happened is many students saw this vaginal discharge and marked it as option number B. Now please remember one thing, students, that whenever a patient has vaginal discharge, it is a manifestation of either cervicitis or it could be the manifestation of vaginitis. So please remember both cervicitis as well as vaginitis, both of them can present with vaginal discharge. And the only way to distinguish the two is you do a per speculum examination. You do a per speculum examination. If there is cervicitis, what is going to happen? We are going to be having features like cervical ulcer, cervical erosion, or cervical discharge. Whereas if it is vaginitis, you're going to be having the characteristic vaginal discharge. Like we know in Canada, there's curdy white discharge. In bacterial vaginosis, there is homogeneous white adherent discharge. In trichomoniasis, there is greenish yellow frothy discharge. So what does this question say? This question says the cervical erosion present. As soon as you see cervical erosion, think about cervicitis. And when you think of cervicitis, you think of kit number 1. And the color of kit number 1 is green color. Next question. HIV adult male, low CD4 count, fever with weight loss. CB-NAT negative. Bilateral nodular lung infiltrates these facial lesions. Now, when we look at these facial lesions, what impression do we get? So if you carefully look at these lesions, what do they look like? They look like molluscum contagiosum. So they look like molluscum contagiosum. And since we know this is an HIV patient, you can have various manifestations of molluscum as well. You can have giant molluscum, extensive molluscum, atypical molluscums, different types of molluscum, because HIV can modify any disease. Further, this question mentions that CB-NAT is negative. So as soon as CB-NAT is negative, automatically disseminated TB cannot be the answer. Now, when in the future exam questions are going to be asking molluscum contagiosum like lesions in the skin, if the disease is restricted to the skin alone, then you can mark your diagnosis as disseminated molluscum contagiosum. If the question says skin is involved plus lung is involved, you can go for disseminated histoplasmosis. Disseminated histoplasmosis. And if the question is going to tell skin is involved with signs of meningitis, CNS involvement, you can go for disseminated cryptococcosis. Disseminated cryptococcosis. So only skin, disseminated MC. Only skin and lung, disseminated histoplasmosis. Skin as well as CNS manifestations, think about disseminated cryptococcosis. So in this question, they're clearly saying bilateral nodular lung infiltrate. So lung is involved. Best answer to go here would be disseminated histoplasmosis. Now let us quickly look at some additional points which are overlapped with other subjects. We'll quickly go through them. Number 1, SEEP classification for varicose veins was asked. Clinical, etiological, anatomical, pathophysiological classification. So we know that according to it, C4A is eczema or pigmentation. C4B stands for lipodermatosclerosis or atrophy blanche. C4C stands for corona phlebectatica. Corona phlebectatica. So C4A was asked. The correct answer for this question is eczema. Treatment of a male with urethral discharge with gram-negative intracellular diplococci on smear. This is talking about gonococci, because gonococci is a gram-negative intracellular diplococci. The treatment for this question is going to be a ceftriaxone injectables. Next question. Lady from Rajasthan, ulcer with perilesional edema on the leg. Microscopy shows organisms with a kinetoplast. So kinetoplast is a very special feature of Leishmania species in microbiology. So with this background of a lesion of dermatology which is there in relation to leishmaniasis, we are going to be giving it a diagnosis of cutaneous leishmaniasis, which usually present with the ulcer. There's usually central crusting. The ulcer is also called as a volcano ulcer, and the organism for leishmania is Leishmania tropica, which was mentioned in the options. Child with perioral dermatitis, mucosal ulcers, impaired wound healing. So an important point given here is periorificial dermatitis. So the nutritional dermatitis associated with periorificial dermatitis with impaired wound healing. Zinc is very, very important for wound healing. It has its role in various stages of healing of the wound. Periorificial dermatitis is very, very important, especially as a feature of acrodermatitis enteropathica. Correct answer for this question is zinc deficiency. Next, there's a child presenting with hair thinning and scaly scalp. So hair thinning means alopecia. Scaly scalp, seborrheic dermatitis. Diet with raw eggs. Raw eggs have got avidin. Avidin binds to biotin and forms a complex which prevents biotin absorption. So biotin absorption is going to be prevented. So you can obviously expect biotin deficiency. So please remember, students, two important key points regarding biotin deficiency. Number 1, presence with alopecia. Number 2, presence with seborrheic dermatitis. Next, patient presents with diarrhea, dermatitis, dementia. Please remember, repeatedly asked question, the dermatitis in this condition is called photodermatitis. It also has a characteristic name to it called as Castle's necklace. It's also called as Castle's necklace. So dermatitis, diarrhea, dementia is a classical triad of pellagra, which is going to be B3 deficiency or niacin deficiency. So with this, we conclude this session of the NEET-PG 2023 exam discussion. So once again, I want to emphasize, kindly focus on the topics of nutritional dermatosis and especially sexually transmitted diseases. So wishing all of you all the very best for the upcoming INI-CET exam. Thank you.